I want to welcome everyone to the Eastman Cares COVID-19 seminar. This is our second talk. We are a group of Ken Dokard and Sally Wood and Elise Kendall and myself who have planned these. As I said, for anyone who has joined us, this is a webinar, so you won't see anybody but the speaker and Paul and I, and we won't see you either. There is no audio, so your audios are all turned off. However, that being said, you will have an opportunity anytime, actually, during Alan's talk. At the bottom of your screen, we are asking you to use the Q&A function. That's a little different than the chat function. It's easier for us to monitor the questions. So if you don't mind, if you do have a question, to just put it in at any time during Alan's talk into what says the Q&A there. Alan's going to pause about halfway more or less through this, and we'll take questions then, and then we'll also take them at the end. Paul will be monitoring questions as we go forward, and he'll handle that aspect of it. So we encourage you to put your questions in at any point, and you'll have an opportunity to be heard. A reminder, in terms of Eastman Cares at least, we do have an updated version of our community resource guide available at South Cove in the entryway or online. We also have the eCares Connection, which is something relatively new, and it offers either daily, weekly, monthly phone calls that are sort of check-in phone calls. If anyone would like to do that, you don't have to be by yourself. Anyone can actually do this, and we have volunteers who will be making those phone calls. So please, we encourage you, if you'd like to talk to somebody about something during this time of COVID, to use that connection. And you will see at the very end of the presentation a slide that will show you how to do that. Basically, you will just email eastmancares@eastmannh.org, and one of us will get back to you. You will also see at the very end, and Alan's last slide, an opportunity if you have other questions you haven't had answered or you think of afterwards, if you want to give us an evaluation, if you want to suggest a speaker, again, use that email and we'll be sure to look at that. This is being recorded, and Alan has agreed to this. Thank you, Alan. It will be on YouTube, and I think for those of you who see Eastman Highlights, you'll have seen the YouTube link for the last talk that we had. So we will be publicizing that YouTube link as well, and feel free to share that. Our next speaker, before I introduce Alan, will be on December 11th, and that'll be Dr. John Sanders. And he is going to speak to us about disease manifestations following COVID-19 and treatment options. So I'm looking forward to hearing him as well. And again, you'll get further information as usual about all that. Okay, finally, I get to introduce Alan, our friend Alan. Alan has had extensive experience working on numerous campaigns for the WHO. He did smallpox eradication, and we're just actually sharing stories about Ethiopia, India, Bangladesh, Somalia. He was in the WHO Geneva office, and then he got a MPH from Johns Hopkins and worked with the WHO at the country and the regional level. So that's like in Nepal and also in the bigger region of Southeast Asia and the Western Pacific. He worked on immunization programs and polio eradication. And then he went to China and spent many years actually in China working on polio eradication and disease surveillance and responses there. So he's got lots of experience. He was a focal point for the WHO in China during SARS. And he also was responsible for doing internal audits and evaluation at the WHO. So he's very familiar with the WHO. Since the WHO experience, he's been an instructor at the BU Boston University Geneva program. He's coordinated lots of courses on international health. He's written book edited. He's been an editor of 2 books on smallpox eradication, and he's written and co-authored lots of book chapters, journal articles, etc. He is a a wonderful friend with a great sense of humor. And on that note, we will let Alan take over. Thank you, Alan.
Thank you, Sue, for the introduction. Very kind. It's quite a pleasure and a privilege to be able to speak to the eCares group this morning. I'm going to share my screen, and for my slides, and that should be up now for everyone to see. So we're going to talk about the World Health Organization, and then we'll take a look at some specific countries around the world and how they're dealing with COVID-19 responses. So first, I'll speak about what is the World Health Organization and the role of WHO in the COVID-19 pandemic response, including the WHO role in the international health regulations as a legally binding treaty. And then we'll look at the COVID-19 response of selected countries, what worked and what didn't, and then find if there are any lessons for the United States. I did, as Sue said, have a chance to work with WHO at different levels, including for 5 years in the Western Pacific region office, covering all the countries in the East Asia, and then also in the Southeast Asia regional office, covering 11 countries in that region as well. So I have worked or visited many of the countries we'll talk about today. So what is WHO? The World Health Organization is a specialized agency of the United Nations. It's not under the Secretary General. It has its own governing body, the World Health Assembly, and the World Health Assembly elects its Director General. So it's coordinated with the United Nations system, that the Secretary General does not have direct control over the World Health Organization. And WHO is the directing and coordinating authority on international health within the United Nations system. So just to put some context of that, this is from the preamble to the Constitution of WHO, written in 1946. It seems very relevant for today, but this was written in 1946. The famous opening that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. So looking at the holistic self, not only at the physical self. Also some other points here, that the health is a fundamental right of every human being, and that governments have a responsibility for the health of their peoples, which can be fulfilled only by the provision of adequate health and social measures. So governments have responsibility, and they must look after the health of their peoples. The World Health Assembly is the governing body of WHO. It sets policies, and there are 194 countries. For some time, the WHO had more member states than the United Nations. There are a few countries like Switzerland, which hadn't joined the United Nations at that time, that were members of WHO. Switzerland has since joined the United Nations. There's an executive board, a subset, that will have representatives from each of the regions of WHO, and they meet twice a year and get into more detailed discussions and feedback to the World Health Assembly. And then there's a secretariat. The current Director General of the WHO is Dr. Tedros Adhanom Ghebreyesus, and he is in charge of the Secretariat. There are currently about 7,000 staff worldwide working for WHO, and the Director General is the head of the Secretariat, nominated by the Executive Board, and then elected by the World Health Assembly. There's been a recent change that now the Executive Board will nominate several candidates to the World Health Assembly. So the World Health Assembly will choose the Director General from among several candidates proposed by the Executive Board. Director General has a 5-year term. WHO has a regional structure, which is the strength and the weakness of WHO. Each of the regions has a regional office and a regional director and a regional committee. The regional committee is made up of the member states within that region. So it means the member states sit on both the regional committee and the World Health Assembly. So there's two bodies that direct the work of WHO. The United States is a member of the Western Pacific region, which we will be talking about, since there are several territories in the Western Pacific region, such as Guam. So one can be a member of several committees. The US also a member of the Regional Committee in the Americas, of course, obviously. So the regional directors are elected by the regional committee. So the regional directors have their own electorate that they're responsible to. They're responsible to the countries of the region who have elected them, as well as they're also responsible to the Director General, who is elected by all the member states of WHO. So this dual responsibilities is a factor in WHO, which we'll talk about later. The WHO 6 regions, the Americas, should be mentioned that the Americas, the Pan American Sanitary Bureau, now called the Pan American Health Organization, is older than WHO. It's been around more than 100 years. And when the WHO was created in 1948, it was incorporated into the World Health Organization as a regional office for the Americas. The other regional offices, the Brown is the Western Pacific, the headquarters in Manila, Southeast Asia region, which is headquarters in New Delhi, the European region with headquarters in Copenhagen, the Eastern Mediterranean regional office with headquarters in Cairo, and the African region with headquarters in Brazzaville in Congo. There are some political reasons for these boundaries. You'll notice that this blue spot here is North Korea, the Korean Democratic Republic, that belongs to the Southeast Asia region. So that's been put in a different region than South Korea, which is in the Western Pacific region. And that's for political purposes. These is a picture of the 6 regional directors and the Director General from the left to right, Americas, Western Pacific, African region, the Europe Director General, European region, the Southeast Asia region, and the Eastern Mediterranean region. I think this gives some idea about the different composition in terms of background, races, religions, etc. of WHO staff. It's quite a diverse organization, and it was one of the things I quite enjoyed working on in WHO. All people from all backgrounds in all countries. So WHO headquarters has responsibility for leadership, preparing global strategies, plans, and guidelines. And when these strategies and guidelines are adopted by the World Health Assembly, they become global health policies. For example, smallpox eradication program started as a strategy, and also then it was a goal set and adopted by the World Health Assembly and all the countries under the World Health Assembly. The same is true for polio eradication. The headquarters sets global standards, for example, water and air quality. I suspect all of you have heard about the WHO water quality, WHO air quality standards that are often referred to in the news media. Also set global standards for medicines and the children's height and weight. It is responsible for international disease control and information on those diseases, including the international health regulations, which we'll discuss later in some detail. Also, there are influenza control. The WHO holds a meeting twice a year where they bring in experts to look at the circulating influenza viruses. And this meeting then sets the content of the vaccines for that year. So they'll look at what different diseases, what different types of influenza are circulating, and the vaccine will be set based on that global meeting, once for the Northern Hemisphere, and then again later for the Southern Hemisphere. The WHO also provides expert support to countries on request. For example, the Global Outbreak Alert and Response Network, which provides experts to countries. It provided many experts to countries during the SARS outbreak in 2003, and is doing the same thing today for COVID-19. The headquarters is also responsible for information collection, verification, and dissemination. The WHO is responsible to work on some global treaties, such as the one on addictive substances under the UN Treaty on Control of these Substances. It has a committee that it forms to review substances and advise if they are addictive and what level of addiction they are. So this is the responsibility to the United Nations and indeed the whole global community. WHO has also negotiated some global health treaties, such as the International Health Regulations, and also a framework convention on tobacco control to limit, not to limit, but to put more scientific controls on tobacco advertising, for example, in developing countries, and the distribution of tobacco products in developing countries and indeed in all countries. WHO has tremendous convening power. It has established expert committees, and it can mobilize experts from around the world to establish global standards and to prepare guidelines. WHO works with the committee on the international classification of diseases. Currently, we're at ICD-11, and that means the 10 have been, previous 10 are now updated to ICD-11. And this is giving numbers and definitions for all diseases so that you can compare disease rates, disease findings across countries. So all countries will subscribe to this ICD-11, and then you can have comparability of findings between countries. There are also many programs have strategic and technical advisory groups, STAGs they're called, that these are composed of globally respected experts. The regional offices also have responsibilities for adapting the global policy strategies and to make them relevant for the countries in the region. It provides technical support to the countries in the region and provides logistic support for equipment, supplies, and people to the countries of the region. This is maybe especially important now during the COVID-19 pandemic, where it is providing supplies and equipment to help countries fight the pandemic. It provides also partner and donor coordination and does fundraising, interacts with the media. The WHO country office is responsible for adapting strategies and guidelines at the country level. It interacts closely with the ministries of health and other partners at the country level, and it knows the country well. The country offices report to the regional offices. So it should also be mentioned that the regional office is the body that appoints the WHO representative. That's the chief of the WHO country office. So the WHO representative is responsible to the regional office and the regional director. Also, there's some responsibility to the director general as well. So there's the dual structure of authority, where the country office mainly responsible to the regional office, but also responsible to the headquarters and the director general. This can have some effect if you have a region with many strong people. You'll find that you can have a higher, more accomplished people working in that country office or in that region than others. So certainly the Americas, the Western Pacific region with Australia, Japan, China, New Zealand have many top-notch experts working in that region from that region. The African region may have less highly qualified staff than the other regions. It also is involved with politics in the region, since the regional director in the African region is elected by the countries in that region and is responsible to the countries. So this different level of performance of the different regions is a strength of WHO, that the countries, the regional office and the country office reflect the countries of the region. It's also a weakness if you have some maybe not the most accomplished people working in that office. There is people working in country offices from other regions as well. It's not only from within the region. So that's also, you'll have people from outside area as well with their expertise working in country office and also the regional offices. Some attributes of WHO mentioned my partners in surveys, and these are surveys that I had done working at the headquarters Internal Audit and Evaluation Unit. They found WHO to be impartial, objective, with a high level of impartial technical support, especially to low and middle income countries, was highly appreciated. For example, in an area like genomics, where almost all the technical knowledge lies in developed countries, the developing countries are happy to have an impartial and knowledgeable referee on their side to help them to work with all of these developed countries, and also private commercial enterprises who may have their own agendas. WHO has convening power to bring experts from all countries together to prepare strategies and or to solve problems. It has access to ministries of health and governments. Given the regional structure of WHO, often there are close contacts with government officials at all levels of the government, and this can be a strength if one needs to have something done in a country. It has a strong presence at the country level, and it's found by the partners to be knowledgeable about country situations. These are a few programs specifically mentioned in the WHO Constitution. So these are written in 1946. Of course, epidemiology and statistics, emergency response, eradication of diseases, biological and pharmaceuticals. I mentioned this just to show you the rather broad background, the broad terms of reference of WHO that's responsible for a very large area of work, and not just for epidemiology and disease control. If we look at the staffing of WHO, what are the resources it has to achieve this very large agenda? So in 2018, WHO had about 7,000 staff working in 150 country headquarters, regional, and other offices. The WHO total budget for 2018 and 19, this is the biennial budget. WHO has a 2-year budget, $4.2 billion. If we compare this to the CDC budget, CDC total budget for 2 years in 2016 and 17 was $14.4 billion. So the CDC budget is more than 3 times the budget of WHO, and also CDC had 15,000 staff working in 2008, so roughly more than double the staff of WHO working in the CDC. It should be mentioned that some of the countries of WHO wanted to keep the budget low. They didn't want to see too much money going to WHO. The United States being one of the leads of that. We'll talk more about that later. So networking, given WHO's limited resources, networking is important and becoming increasingly more so. There are WHO collaborating centers, about 800 of them scattered throughout the world, that don't work directly for WHO, that will support WHO programs. There are disease surveillance networks. There's global disease laboratory networks. For example, there's an influenza lab network, also a polio lab network, among others. There's the GOON, the Global Outbreak Alert and Response Network that I mentioned, works with WHO, works with civil society, with non-governmental organizations like Doctors Without Borders, the Red Cross, and many others, Oxfam and CARE and others. It works with centers of excellence, such as the US CDC, the European CDC, China CDC, and Japan National Institute of Infectious Diseases, and many others. Centers of excellence. Also works with universities. Many of the experts on WHO panels coming from universities, such as the London School of Hygiene and Tropical Medicine, University of Geneva, Johns Hopkins, Harvard, North Carolina, etc. The governance, the global governance of health has been changing in recent years. And I put this diagram, this is GAVI, is the Global Alliance for Vaccines and Immunization. It's around for several years now. Now it's called the GAVI Alliance, and it's the aims to support immunization programs in middle and low income countries to provide them with vaccines. And the structure is you'll see that WHO has one seat on this. So in the past, these work would have been done by the World Health Assembly. Now it's being done by these partnerships, as they're called. GAVI is one. There's a rollback malaria partnership. There's a global fund to fight TB, AIDS, and malaria. That's also come up, and many other partnerships as well. The TB partnership being another important one. So WHO has one seat on the governing body of this GAVI. industry has seats. You'll see several. The donor countries have 5 seats, and the developing countries have 5 seats. Also, you have the Bill and Melinda Gates Foundation has a seat on the board, and other research institutes. So it's redistributed power. Previously, the World Health Assembly set the agenda, and this is all countries with one country, one vote. Now these governing bodies of these partnerships more tilted, I think, towards developing countries, also involving industry. And that's taking place now, and these partnerships have quite a bit of funding and also quite a bit of power when talking to countries to push them to set agendas that will match the guidelines of these partnerships. And that's a recent development. It's tended to reduce the power of WHO with the countries. I should also mention that GAVI is involved with the COVAX facility. That's the facility that's going to procure a vaccine and distribute it for COVID-19 for developing countries once a vaccine is available. The WHO working on international health regulations, and this is a poster from the CDC, our CDC Atlanta, that the idea of international health regulations is to detect potential candidates for a pandemic, assess whether they are really threats, to report on them, and then to respond. So this is the role of the international health regulations, and we'll discuss how that is put into effect. So there's a few milestones. The previous international health regulation was 1969, and it was felt for quite some time they were inadequate. They were based mainly on diseases, just a handful of diseases, and only could respond to official formal reports from countries. It was wanted to expand to look also at informal reports and also to look more at syndromes. And there was a discussion was going on for many years. I got involved in that back already in the early 1990s. But it took the SARS outbreak in 2003 to really get the countries motivated and realize that something had to be done rather quickly. And SARS, of course, was not a recognized disease. It was a new disease and could be identified only by the syndrome at the beginning. So it was not reportable under the previous international health regulations. In 2005, they were agreed to by all the countries. And then they came into force 2 years after adoption when enough countries had ratified them. And that was in 2007. So the international health regulations has to be a balance. There are global concerns. We know our president, for example, is concerned that was not able to go into China to look at what was happening there with COVID-19 at the very beginning of the COVID-19 pandemic. We need to have rapid response. On the other hand, there's national autonomy issues and individual freedoms, people's freedom to not have their personal information shared. So this dynamic and dilemma, the US fought quite hard in the discussions about the international health regulations to not have other countries coming in to visit the United States. One can imagine what the US response would be if China and European countries said, we want to go into the US and look at your response to COVID-19 because it's a risk for the whole globe. We can assume the US would not be very responsive to that request. So the other countries at the discussions also were concerned about their national autonomy. Also, there are global disease control requirements to get in quickly and to take necessary actions. But also there's issues about freedom of travel and effect on the economies. Some previous epidemics were just a few cases. One thing, the plague outbreak in India, where the country responded by shutting down air travel. So a huge effect on the Indian economy, even though the plague cases were very few and really not very consequential for international spread. There was overreaction and had a major effect on the Indian economy. So the intention of the international health regulations was not to, in fact, impact unnecessarily on countries' economies. There's also the issue of accountability and external scrutiny, but also the need to have standardized and predictable procedures so countries knew what they were getting into by reporting. If the countries didn't feel comfortable, they may not have felt necessary to report. That's always a dynamic. since there's no policing for the international health regulations. The WHO has no police force that can go into a country if they're not reporting properly. It's each country has to report on their own. So there was a notification instrument within the international health regulations, and there's the countries to decide whether there's a need for notification. They can ask, is the public health impact of the event serious? Is the event unusual or unexpected? Is there a significant risk of international spread? And is there a significant risk of international travel or trade restrictions? These are the questions that one would ask about an event taking place in your country. In addition, there are 4 diseases that must be notified. Smallpox. One case of smallpox would be a public health emergency and of great international concern since it's been eradicated. Also SARS, wild poliovirus polio case. There are very few left in the world. Also human influenza caused by a new subtype of influenza virus, such as H5N1. Also some other biological, radiological, and or chemical events will meet the criteria. The international health regulations also covers some radiological events, such as another meltdown of a nuclear plant releasing radioactive into the air, and also any biological event. So this is the event management flow. No need to get into this in great detail, but just to mention that under the new health regulations, formal reports, that's from a country. The country reports, we have a report of a disease here that we're following up, but also informal reports now allowed. That was a change in the new health regulations, that the countries can also, the WHO can use informal information such as ProMed or a newspaper article. And then that goes into screening and the triage, and then into verification. Then there's event risk assessment done by the WHO, and then it will be go to a manage this after considering the event. So the event will go to WHO and to decide, does this qualify as a public health emergency of international concern? And that's, as provided in international regulations, the definition of a public health emergency of international concern is: 1, does it constitute a public health risk to other states through the international spread of disease? And 2, to potentially require a coordinated international response. If it's a disease spreading in a country but not of high risk of international spread, then it would not be declared a public health emergency of international concern. A public health emergency is declared by the WHO Director General on the recommendation of a specially convened emergency committee composed of recognized experts. Since there's such a wide range of diseases, conditions, and even a radiological event that could be up for consideration, you need to have the experts for that particular disease or that particular event. So the emergency committee will be composed for that event. In the period 2009 to 2020, there have been 6 public health events of international concern declared by WHO. The H1N1 influenza in 2009. One could talk a lot about that. We don't have time to talk about it today. It wasn't quite as severe as originally thought. Polio in 2014, as part of the polio eradication effort. Ebola in Western Africa in 2014, Zika virus 2016, probably all remember that. Then Ebola outbreak in Central Africa, the Kivu in the Democratic Republic of Congo, 2019, and now COVID-19 in 2020. For a 1-year period, and this was taken from an assessment report of how the IHR was functioning, there were 321 potential public health events of international concern reported to WHO during this about 1-year period. All of these have to be assessed, followed up, and then a decision taken whether to declare them a public health event or to discard them as more of national significance. The U.S. involvement with international regulations, the U.S. as a member, the Department of Health and Human Services is the national focal point for the United States and responsible reporting to WHO. The DHHS has to, though, coordinate the responses of all the other U.S. federal agencies involved in IHR implementation. And you can see quite a long list: the Department of Agriculture with food, Department of Commerce, Defense, Nuclear Regulatory Commission, the Homeland Security, being responsible for customs and inspection. So a whole list of things that must be coordinated by IHR. I will say that when I was working in China and we had requested the government of China to please nominate for us, to please tell us who is going to be the national focal point in China for the international regulations, we received back 2 letters, one from the Ministry of Health saying that we're the national focal point, and one from the Chinese State Administration for Quality Inspection so the inspection of commerce and importations. So we got these 2 letters saying that we're the national focal point. We then send that back to each of them saying, could you guys please talk to each other and then inform us who's the one national focal point. So it's not always such an easy decision to see who's going to be the national focal point. So what happens if the US withdraws from WHO? The US has officially informed WHO that it will withdraw in July 2021. That's 1 year after the notice, as required under the US joining signatures. So the US will no longer sit on the executive board, will no longer control the budget of WHO. It's worked very hard to keep the budget of WHO small. And as mentioned, the assessed budget, that's the fixed contributions of the member states, has declined as a proportion of the total WHO budget. It's been fixed largely because of the influence of the United States, with the extra money coming in from donors as voluntary contributions. Unfortunately, the donors often will specify where they want this money to be used, whether for TB or for polio eradication. So it doesn't leave WHO much flexibility on how it spends its budget. So if the US leaves, probably the WHO budget will be increased by the other countries and given more flexibility. But also US citizens will no longer be given preference when selecting WHO staff. The US has provided protection for the pharmaceutical industry and also private sector enterprises, which will end. And the US will lose access to countries and also a loss for WHO and least developed countries, which will receive less benefits from the US expertise provided through a multilateral agency. This is just a quote that shortly after President Trump announced the US would be withdrawing from WHO, the ministers of health of France and Germany visited to Geneva to pledge their support, increased support for the WHO. And this at the press conference after the meeting of the Director General of WHO with the health minister of France and Germany, he announced, the Director General said, "Now more than ever, the world needs leadership. I offer my profound thanks to France and Germany for your leadership and support." Of course, the unspoken message there was that we'd really like to have US leadership for this pandemic, which was not the case. So they take a bit pause, a bit longer than I had expected on this, but happy to open up here for questions.
So we do have several questions. They're somewhat related, and you have responded to some, but by leaving WHO, does the US break any international treaties?
No, as I understand, the United States, as part of their joining documents to join the WHO, had included a provision that they could withdraw if they wanted to. I believe the US was the only country that put that stipulation into their joining agreement. So it's within the US rights to withdraw from WHO. And I assume then they can also withdraw from the international regulations if they wish as well. Now, what effect that would have on other countries' view of the United States, that's a different matter. You can meet the letter of the law and maybe not necessarily the spirit of the law.
And one other question, is this unprecedented, I guess, in terms of the US saying that they're going to leave WHO?
Not unprecedented. Some countries have withdrawn from the United Nations and WHO and then rejoined again later. So it wouldn't be the first time that has happened.
But has the US ever?
No, the US has been a leader of the World Health Organization since its formation. There was a bit of some contention under the George W. Bush administration where they stopped paying the United States contributions to the WHO budget, but that was then brought up to date. So no, the United States by and large has been a leader in the WHO.
And finally, can the U.S. rejoin without any sort of lapse in responsibilities or position, its standing within WHO?
Yes, it can rejoin. It should be mentioned that the U.S. gave 1 year notice, so the U.S. would not officially withdraw until July of 2021. So that it hasn't withdrawn yet, but even if it did withdraw, it could rejoin again later. Now, whether the other countries would then remember that in future, that's another issue. Again,
Okay.
the letter of the law and the spirit of the law.
Well, thank you. Those are the questions. And just as a time check, it's about 1:45.
So we're yeah, 35 minutes in. Okay.
Okay.
We'll have to go a bit quicker than expected. Okay, I'm going to share the screen again.
Okay.
So we now move to COVID-19, and this we're going to try to go around the world in 30 minutes, maybe a bit less actually. So it's going to be quick. Just like Phineas Fogg, we may not be able to linger as much as we like to in some places, but I'll try to get everything in. Eventually, the slides presentation will be up. You can look at it in more detail, and also there will be the video on YouTube. You can look at the slides and stop it, and look at the slides later. So I may be going through a bit faster than I would have wanted to. So in terms of the background, we know that the first reported case of COVID-19 in Wuhan on December 1st. I think they'll probably find the cases earlier than that when the full investigation is done. That's my opinion. The WHO was involved early on. On 11 January, the first sequencing of the SARS-CoV-2 virus was posted by researchers from the Fudan University in Shanghai in China. And Germany and Japan then rapidly developed their lab tests in less than a week. These tests were available if the US had wanted to use them. The WHO reported out the claims, and it came up on the agenda in the middle of January. On 20 January, China informed that the human transmission was occurring, and the WHO sent missions to China. By mid-January, things were already blowing up a bit. So on 22nd, 23rd, the emergency committee was formed to look at this if they thought it should be declared as a public health emergency of international concern. But the committee found it had not yet met the requirements. There was some disagreement, not unanimous decision of the committee, but they recommended to DG that it did not yet meet all the criteria to be declared a public health emergency of international concern. The DG agreed and did not declare it. That was on 23rd of January. But later on, then suddenly the disease was spreading, and you had cases in 23rd of January, South Korea, Singapore, Vietnam, Malaysia, France, and Italy by the end of January. So the situation changed dramatically before the next meeting of the emergency committee. And they then recommended on 30 January to declare a public health emergency of international concern, which the Director General did. The name of COVID-19 was given on 11 February by WHO as a disease caused by the novel coronavirus SARS coronavirus number 2. The SARS coronavirus number 1 is the virus that causes SARS outbreak in 2003. The first case was in Spain on 2nd of February, and then Europe increased dramatically, and it was circulating largely out of control. And then in mid-March, the first case reported in New York City, again starting large outbreaks with many cases and deaths in New York, New Jersey, and in the Northeast. On 11 March, WHO characterized COVID-19 as a pandemic. So the role of WHO in the COVID-19 response, as we mentioned, the Division of Surveillance, collecting information on the disease, declared a public health emergency. It's coordinating global response networks. It shares guidelines, training materials, and information on the disease. which have been quoted in the US media, certainly, but also these are quite valuable for many of the less developed countries who need these materials to get their health systems up and running to fight the COVID-19 pandemic. It's also mobilized technical support and funding equipment to help low and middle income countries respond to the pandemic. The Global Outbreak Alert and Response Network has been mobilized to provide experts and technical support to countries. And WHO has set up 3 global virtual networks similar to those that were set up for SARS in 2003. One on laboratory and diagnostics, one epidemiology, and the third one on clinical treatment. These are networks that meet virtually, so you have sign in on secure websites, and that people can discuss openly the latest findings and try to come up with some consensus on improving treatments, also laboratory tests, and the epidemiology of disease. This is really valuable for spreading information between countries. WHO established the COVAX, the COVID-19 Vaccines Global Access Facility, with partners such as GAVI to provide COVID-19 vaccine to low and middle income countries that may not be able to afford to provide billions of dollars to the vaccine manufacturers to get the first dose of the vaccine. And the US has decided not to join the COVAX. It's also established access to COVID-19 tools to develop, procure, and distribute new tools such as new laboratory test kits, new therapeutics for all the countries, not just the richer countries. And it's also mobilizing equipment supply chain system to provide PPE and lab equipment for low middle income countries who may have difficulty bidding against the developed countries for this rare and valuable equipment. No need to read this slide, but it's an example of a research group that was conducting trials of 4 drugs, remdesivir, hydroxychloroquine, lopinavir, and interferon for its effectiveness for hospitalized COVID-19 cases, and it found no effect. I list all these countries here to show that 29 countries took part in the study, and the US was not involved. So even if the US withdraws and doesn't want to get involved in the global response, other countries are there and can take up the work and keep things moving, but even without the United States. Before starting to look at countries and their response, I thought to look back to SARS. This is from 2003 largely. The first cases found to be started really in November 2002. So these are the countries mainly affected, mainly in Asia. So you have the yellow color is the outbreaks before the 15 March global alert from WHO. So China, Hong Kong, Vietnam, Singapore had large outbreaks with quite a bit of spread. It was a really stressful time. One wasn't familiar with this new virus, wasn't sure how dangerous and how infectious it would be. Taiwan also had a large outbreak, but also Korea had 3, Malaysia, Philippines, Thailand, Australia had early cases. So these countries were sensitized by this SARS experience. They didn't need any notice to tell them that there were dangerous coronaviruses out there. They were already aware and on the lookout for it. This is from a presentation I made on emerging infectious diseases. This is MERS, Middle East Respiratory Syndrome. This is another coronavirus-caused disease that's popped up in the 21st century. It's mainly related with camels and people coming into contact with camels. It doesn't spread so easily from person to person, except in South Korea in 2015, they had a very large outbreak with spread human to human, largely in hospital settings, to about 186 cases with 36 deaths, so a 19% case fatality rate. So South Korea already aware and that this coronavirus could cause fatal diseases and it could spread. If we go back and look at the spread of coronavirus from early on, and this is from 19 February, there the map, you can see the red dots. You can see from the number of confirmed cases, 1, 2, 3 to 10, this is rather small numbers compared to today. So people aren't expecting to get as bad as it has. But the main cases in China was the main outbreak, also Australia, Malaysia, Singapore, Korea, Japan having cases as well. European countries, some, but not so much, and US and Canada, not much at all. By March, the situation had changed. The outbreak had spread in Europe, many European countries reporting outbreaks, added another category for more than 10,000 cases. But the US and Canada and the Americas, still relatively small outbreaks, not heavily affected by COVID-19. We fast forward to June, it has changed because they found that if you use red dots, the whole map would have been all red. So they now used to look at cases reported in the last 7 days. Again, a yellow color indicates not many. You can see that Vietnam, Thailand, not many cases in June. Also 100 to 1,000. China, Japan, South Korea, and Australia also with very few cases. But the outbreak then spread to the US and to South America. So already the outbreak spreading from Asia to Europe and now to the Americas by June. If we look fast forward to October 8 of 2020, this is a weekly report, and these are cases reported now per 1 million population. We're not reporting number of cases, but the population per million. Still outbreak remaining quite high in the Americas, and now Europe getting a second wave as well. But if we look at Asia, China, still low levels of transmission in Asia. They seem to have controlled the pandemic there. This is looking at a graph by region, WHO region, 600,000 cases. This scale on has been going up each week by week. This is a total confirmed cases of 53.7 million. So you can see in COVID-19, if you're a few days behind, it's already out of date with 1.3 million deaths. But you can see this small blip over here. These were the few cases in Asia, China, and so for the Western Pacific region. And you can see that disappears afterwards, very low, a bit more here, pop up with outbreak in the Philippines and Singapore, but largely small. Then a European region popped up, and then the Americas, and Americas never subsided. And now the European region, again, getting more cases of the second wave. The green is from the Southeast Asia region, which is mainly India and other countries in Southeast Asia. It was up and still high, but now it's leveling off. The sort of pink color here is Eastern Mediterranean region. Not many cases from a global perspective, although some cases having larger outbreaks like Iran and Saudi Arabia. The African region, not much. They had a pickup in July, August, but relatively less cases compared to the other regions. If we look at new cases per million population, we see the United States among these selected countries that I've selected. The US is the highest, then Germany the next highest, and this is updated up to November. I have access on 15 November, so out of date, but not so much out of date. And then Norway, the other one. Here on the bottom, these are the Asian countries, very close to 0 per million population, these being Vietnam, Thailand, Singapore, and Australia. Australia had a few blips early on, and then again during their winter season in July, August, but now pretty much under control. Quite remarkable, the difference in these different countries and different regions. So as discussed, the map showed the spread from Asia to Europe and then to the Western Hemisphere, now returning to Europe. The South America is so heavily infected. Africa has had cases, but not yet so heavily infected. We'll talk a bit later whether that's real or they're just not finding any cases. But many East Asian countries have control of the spread, and maybe some lessons to be learned from that. Looking at strategies, already in April of 2020, so this is, we're talking of 6 months ago, the WHO updated the strategy document, and the introduction pointed out that the faster all cases are found, tested, and isolated, these 3 components, the harder we make it for this virus to spread. And this principle will save lives and mitigate the economic impact of the pandemic. So already looking at saving lives and mitigating the economic impact. The introduction signed by Dr. Tedros then goes on to say that we must stop the cases from becoming clusters and clusters from becoming explosive outbreaks. must put in place capacities for testing and diagnosis, isolation, contact tracing, and quarantine. So these are 4 aspects very important. We'll look later at how well countries have achieved that. Also, the DG said we must engage everyone in the response, meaning all people must be involved, they must be educated and involved in the response if we are to be successful. So not only the country taking necessary action, but the people must be involved and also contribute to the response. We'll talk later about how that's going in the United States. So this is a system that on the WHO website that I'll explain later how to find it if you want to look up further. So this was Oxford University in England. They had a government response tracker and they looked at 18 indicators. They looked at public health, public information campaigns of the country, testing policy, contact tracing, the investment in emergency services, such as providing enough PPE, investment in vaccine development, facial coverings, miscellaneous policies. Also, they looked at containment and closure policies where there are lockdowns, so where there are school closings, workplace closings, where public events canceled, where there are restrictions on gatherings, closing of public transport, stay-at-home requirements, restrictions in internal movements, and any international travel control. These are all things done by the governments of the countries. So income support for households under economic policies, debt contract relief, fiscal measurements, and international support. So these 18 indicators of how countries were doing with these, applying these indicators, is what the Oxford University used to rate countries. So we'll look at one, and we're going to go through these quickly. Vietnam, we can see they have a total of 1,265 cases. That's not daily or weekly. That's the total cases they've reported since the start of the pandemic. Much different than some other countries. So when the first cases reported, again, Vietnam had a SARS outbreak, really caused panic in the country in 2003. Immediately ratcheted up their stringency requirements, and then there were more cases, or even further, it went up to very high, almost to 100% on the index of the Oxford University. As the cases came down, they lowered the stringency, opened up a bit, let the economy get back a bit. Then there were another outbreak, again ratcheted up their stringency requirement to shut down the outbreak, and now bring it back down again. You notice the scale here. Look at the scale in these different countries. Here we're talking about, these are cases per day, new cases per day. So 50 is the scale for Vietnam. The US could only dream of that. So Thailand also had early SARS case in 2002. When the cases appeared, immediately ratcheted up their control of the government, their recommendations, and their under the stringency index, and maintained it as the case went down, and then lowered it, now lowering it more. So opening up their economy, cases kept quite low in Thailand. Total cases 3,866 so far. South Korea, another success story, also heavily affected. Someone returning from Wuhan immediately ratcheted up their stringency index. That means control measures were implemented to shut down the movement and to increase public health interventions. And they could then lower it down as the cases were reduced, and have been keeping it fairly low so far. Cases coming up again, a second outbreak, but being controlled. Total of 28,000 cases so far for Korea. Singapore, another success, and some lessons here. So they had early cases, immediately ratcheted up their control policies, and when more cases came up, then increased even more. Should be mentioned that in Singapore, among the resident population, very well controlled, not many cases, but they didn't pay enough attention to the immigrant community. These are workers who are coming to work, living largely in dormitories. Cases got into these dormitories and had explosive spread and cases, dramatic spread in the country, and it took them a while to get under control, but now again back under control. This is a warning for countries that don't pay attention to migrants and other disadvantaged minorities. Again, the total cases 58,000, including the big outbreak among the migrant and immigrant workers. Malaysia, a similar story. Again, with 46,000 cases, having a bit of outbreak again. Malaysia, the same reason that, again, this is among their migrant workers and undocumented immigrants who were working illegally in Malaysia, coming from neighboring countries, and having the outbreak largely among these people. Another warning for countries that don't pay enough attention to disadvantaged minority groups. Australia, a similar situation. They had a big uptick in April, and they then ratcheted up their control measures to bring it down. Some warning here that July and August, of course, is the winter season in Australia, and they had a big uptick in cases. Now, again, under control as it continues. But there was a warning for the Northern Hemisphere that when winter returned, this disease could come back again. From experience in Australia, also in New Zealand, similar experience. New Zealand done a very good job of controlling this outbreak, a total of 1,600 cases. Very well done by New Zealand, and certainly a model for other countries. We look at Japan. Japan never ratcheted up its stringency index, didn't take much control measures, and yet they're controlling the outbreak, 116,000 cases so far. It should be said that the government wanted to have the Olympics in Tokyo in July, so there wasn't much done before July. Only after July, then the government started ratcheting up to take more control measures, also to release more information to increase their testing. But despite the lack of a very robust response from the government, Japan has not had many cases. We can think that that could be due to the response of the people. Response, and also accustomed to wearing masks and to being concerned about the health of their neighbors and their community as well as themselves. Germany as well was taken as a success story, having outbreaks now and now many cases, but they never took very stringent measures as other countries had. Only the maximum was 75 at the early stages of the pandemic, but could manage to control it until recently. Sweden has been called a role model for this herd immunity strategy that is being promoted by some in the federal government. But they've had a lot of cases, 177,000 cases. We'll see later also quite a high fatality rate from this disease. But they never took very strong measures to shut down the economy. Schools remained open. People could move around. Mask mandates were not rigorously applied, but now having a bigger outbreak, despite having more cases before, not clear how good a success this so-called herd immunity strategy has been in Sweden. Looking at Norway, we're just neighboring to Sweden, took much more stringent actions, a much higher rating on the stringency index, and shut down the pandemic. Now getting a few more cases, but still a total of 27,000 cases. Norway has about half the population of Sweden, and with only a fraction of their cases. So one can discuss whether Norway or Sweden have a better response. The United States, Paul has already talked about that last week. You can see the scale here is off the scale. So this is for this 10 to the 4th. So this scale is, this is new cases. This is 50,000 cases. And this is 10 to the 5th or 100,000 cases. Just a huge number of cases compared to other countries we've looked at. And the total as of last week was 10.6 million. But the problem here is that the stringency index doesn't do very well in the federal system. So how do you accommodate the response in different states of the United States? There's been very different responses by the different states in terms of shutdowns, mask mandates, closing of schools, etc. So that's rather difficult to combine into one stringent index. And I think this rating here reflects that difficulty. Some of the states may not have that high stringent index. Looking at one country in Africa, in Ethiopia. So at the very beginning of the pandemic, ratcheted up very high to try to shut down the cases, and could succeed for a while, but now spreading. We'll talk later that most of the cases detected in Addis Ababa, which is the capital, not many from the countryside, and that could reflect a lack of surveillance and lack of testing rather than the actual situation. But Ethiopia so far only 102,000 cases, it reflects similar experience with other countries in Africa. This is a rather poor quality photo, but to show that people, from a New York Times article, it was people lining up to buy masks in South Korea. So people took the mask mandate very seriously in South Korea, and people wore a mask to protect others and themselves. And we can see what effect that's had on the progress of the pandemic in South Korea, also other countries that we've discussed. In terms
Alan, if I may, the stringency data feeds very closely into this question, and you may have answered it already, but what do you believe the key factors were in the prevention of a second wave in many Asian and Australian region nations versus the Americas and Europe?
Okay, and we'll get to this a bit later, but mainly I think you had good governments taking rigorous action, letting the scientists dictate what action is required, and also people trusted their government. People saw themselves as involved in the response, especially if they had lived through the SARS outbreak in 2003. They were aware how scary it was. So there's good collaboration from the people. And if you have a good government response and good collaboration with the people, you can get that, what we've seen in East Asia. It should be mentioned that some of the countries like China and Vietnam, with authoritative governments, could take very drastic, severe responses on lockdowns, which would be more difficult in a more democratic run country. But we could also see that in South Korea and in Thailand and in Australia, New Zealand, Japan could also get good results even without this very draconian lockdowns that they used in China and Vietnam.
Okay, thank you.
So look, and I'm a bit behind schedule, so we're gonna have to speed up the travel. Contact tracing, again, it's looking at three aspects: limited tracing or comprehensive tracing of all cases. The United States, and this varies by country, by state, not tracing all contacts. It's in New Hampshire where they've given up trying to do that. But the countries in East Asia, almost all of them doing very rigorous contact tracing, with the exception of Japan, and Europe as well doing rigorous contact tracing, with the exception of Sweden and Finland and the UK. Testing policies, this divided up into four categories. No testing, which only a few countries have. Symptoms and key criteria required to get a test, as the US was doing early on in the pandemic. You need to have symptoms and have visited China, or else they wouldn't test you. Anyone with symptoms can report. And then there's open public testing that was first set up in Korea. Korea had the first drive-through testing. Germany also has been doing that as well. So you can see the different response by countries. Surprisingly, some of the Asian countries doing very well, Australia, New Zealand, and Japan, still have only testing with symptoms, not everyone. The US says test everyone, but I think that could be varied by state and also the resources available. So to summarize them, you had the strategy two, anyone showing symptoms in some of these countries, successful countries, Thailand, Singapore, Japan, and Norway, only testing those showing symptoms. Other countries, South Korea, Malaysia, and the US testing everyone, open public testing for everyone. And then you have Ethiopia and Africa, only testing those with symptoms and that meet specific criteria. So still rather restricted testing in Ethiopia, and I suspect other countries in Africa as well. To testing results, the rule of thumb was you should have a test result, keep it under 5% of the test should be positive for COVID-19. That varies by country, and also it varies by how much testing you're doing. If you're only testing symptomatic people, you would expect to have a higher rate than if you're testing anyone who feels they might have been exposed coming in. So there is some different interpretation needed for the testing results, but the rule of thumb has been what's the positivity rate. You can see the United States up about 6-7% at the time this slide was made for 20 October. It's more now, and whereas in Japan and the Asian countries, much less. Vietnam is under 1%, Thailand also under 1%. But this indicator is important. We'll look at it a bit more in detail later. So daily COVID-19 testing for 1,000 people, Singapore having the highest rate. The United States rate is high, but it's not clear whether these are people tested or tests performed, who's being tested. These are aspects that need to be looked at as well. Are you doing thousands of tests on NBA players, for example, or are you testing people in high-risk areas in the migrant communities? That's important. And again, you can see that the testing rates rather low for the South Korea, Thailand, and Vietnam. They have low numbers of cases, but targeting their testing. So this one combines both cases per million and the tests per million. You could say that, well, Vietnam, Thailand, South Korea have lower testing per million and also lower cases. So maybe their testing is a factor of they have less cases because they're doing less testing. I don't think that's the case. Singapore doing a lot of testing, but not with very many cases. Although they did have a high rate per million population. Again, these were mainly the migrant workers, not the resident population. The US, the highest in terms of the high number of cases and high rates. You can take a look at this slide later. So looking quickly at testing rates policy, this was also indexed as part of the Oxford University testing. The tests per 1,000 population, these gray bars, and the positivity rate. So you can see Korea had testing everyone. This is strategy 3, had about 2% of the specimens returned back positive. And we'll then look at Singapore. Singapore only has this strategy 2, only symptomatic people. They had a big uptick. This is the positivity rate was almost 10% early on. This is week 20. So week 20, you divide that by 4 to get the month. That would be in May during the outbreak among the migrant and immigrant communities, and then brought down, now having very few, low rate of positivity rate. Japan, similar, very high at the beginning, the rate, but now they're also a lower rate, about I think 3 or 4% positivity rate. But they started off with only testing those who had the criteria. Again, it's changed after July, after the Olympics were postponed. That may be just a coincidence that date. And now they're testing symptomatic people, but still a low rate. Germany now, the positivity rate has ratcheted up. They were very low for a long time, now up to about 8%. So Germany has an outbreak and it's spreading with the positivity rate. 8% of all the specimens tested were positive. Norway is still very low at the 2% positivity rate. It started off with very restricted testing and then changed that also sometime in July. And now still at the rate only testing those with symptoms. We look at the United States, had a big jump in the positivity rate, very high, and now back up again. It's up to about 10%. So 10% of the specimens collected in the United States are testing positive. And although the specimens are high, that reflects on the outbreak in the United States. It's spreading very rapidly. Looking at Africa, you can see again, Ethiopia only is testing limited numbers. Their positivity rate is 10%. So it's high. We can expect that they're not picking up all the real cases. So just to look at Singapore, I want to point out a few things here that this is the update that they put out with joint WHO and the Singapore Ministry of Health putting out on 4 October that they had very few deaths. The last death reported was 14 July, so no deaths from 14 July to 4th October after they controlled the outbreak among the migrants and immigrants. And they mentioned that there were 167 cases are isolated and cared for in various community isolation centers. And the other 43 cases are in hospital. So none of these cases were sent back to their homes to under their own supervision. They were isolated in isolation centers to prevent spread. The country now is expanding as the cases remain low. Singapore is expanding their economy and opening up. These I put up just some interesting data. We know that some countries, China, South Korea, have tracking software on people's smartphones. This is what some of that data will look like. This is data from Google in 8 countries. just to show what's possible and what's being done in some countries. So we can look at the number of COVID-19 cases and deaths. The main purpose of all these things we are doing, these non-pharmaceutical interventions, these therapeutics, vaccines, is to prevent cases and deaths. And we're not going to go through this all at once. You'll be able to see this later on the presentation that you'll get a copy of. But you can see that total cases per 100,000, the US is highest in that among the countries I've had here. Other European countries also with a high rate per 100,000. If we look at the case fatality rate, or it's a crude case fatality rate, or proportion of fatal cases, it's because we're not comparing all the cases, not retrospective. This is a rough, crude division of the deaths divided by the total number of cases reported. But we know that deaths lags by 2 to 3 weeks behind reported cases. So say in the United States, where you have 1 million cases reported in the last 7 days, they wouldn't be expected to be at risk of the death yet. So this rate for the US is rather low, lower than the reality. If you go down to the bottom of it, you can see that Vietnam, New Zealand, Thailand, 1 case per 100,000, 34, 6. So these, South Korea, 56, these countries controlling the pandemic. You can look at also the death rate per 100,000 for these countries, under 1. So these countries really have control of the pandemic, and also their case fatality rates rather low. But again, they don't have many cases spreading at the moment. So this case fatality rate would be a bit more accurate here than in Europe or the US, where cases still spreading. So for some discussion, and we're getting to wrap it up. I'm 5 minutes over my target time. So some countries have successfully contained the coronavirus, as we have discussed. They've been able to keep their economies more open. These countries with science evidence-based response to the epidemic more successful. Also, were all the people involved in collaborating more successful. And we've seen fewer cases resulted in reduced fatality rates, which makes sense. They're better able to focus on few cases. Contact tracing testing, important. And also, as I mentioned, that more authoritarian countries can lock down, but other non-authoritarian countries have also succeeded. Risk communication is very important to the people, to involve the people in as an important component of the successful government responses. And we've seen that countries that had more warning about COVID-19 did not always use their time wisely to prepare. And some countries with less stringent government responses have been successful in controlling the pandemic. And I think this illustrates the importance of people's involvement and collaboration as a major component of a successful COVID-19 response. I repeat that for the 3rd or 4th time because I think it's really important. And of course, the rich get richer, that those countries which kept cases low, better able to focus on and successfully implement contact tracing and testing to stop outbreaks before they happen. So we saw that Australia and New Zealand had an increase in their winter months, and we're seeing that now happening in the Northern Hemisphere as well. Singapore and Malaysia neglected their migrant workers, and I would also include minority communities on that as well, and they paid a price for it, but they've caught up. And also that France and Germany have pledged support for WHO and the global solidarity. So if the US was to pull out, other countries would then be able to pick up some of the slack. So what are some lessons for the US is the last slide. Science needed to respond to a pandemic, and other countries have adopted a nationwide response involving the government, people, industry in fighting the virus, similar to a war footing. And that's a lesson the US could maybe benefit from. National response also be useful, involving all citizens in the response. Has not been done by governments in all the states, and they need to better promote the use of face masks. I will note that just yesterday, New Hampshire finally joined the list of states that have a mask mandate. So need an international response to address COVID-19 can't be done only in one country. And if the US does not participate in the international efforts, other countries will carry on. But there'll be a loss for other countries. They'll lose US expertise and leadership, but the US will also lose. These are some websites for up-to-date information. As I mentioned, the data I showed from last week is already out of date. So the WHO.int, if you click on the COVID-19 link, and then you click on the Explorer tab, it will take you into you can look at each country individually. Also the Johns Hopkins website, CDC, of course, website, we hope that they'll be getting a lot more data on their website in the coming months, after January 21st, for example. The New York Times also has good data mapping, tracking of the COVID-19 as an ourworldindata.org. This is the Oxford University, and they're mapping data on coronavirus as well as other development indexes, and of course NIH.gov and Health Vermont. And finally, it's been my pleasure to make this presentation to the Eastman Cares Project, and as Sue had said, if you have other questions. And with that, I'm happy to take more questions. Apologies for going over.
We have one question, and that is, do you believe that it's now necessary for a national lockdown?
Of course, a lockdown doesn't hurt if you're controlling a virus. You can interrupt transmission. If you had everyone to faithfully stay in their house and lock themselves up for 2 weeks, so the virus would die, because unless the virus can transmit to someone, it dies off. People recover and the virus can't transmit. But of course, that's impossible to do that. So I'm not sure that the US has any room for a nationwide lockdown. Health is a state matter. The federal government does not have responsibility for implementing health programs. The federal government could probably suggest a universal mask mandate, but it will be up to the governors within the states to issue executive orders. So do I think it'd be useful? Yeah, I think that a mask mandate would be very useful. Of course, applying it and getting people enforcing it is a very different issue than making the mandate. But in the meantime, the state governors can take action themselves.
That's all the questions that we have in the Q&A. Unless I see another one being typed soon. I think that I have to turn it back to Sue.
And we want to thank everyone who participated. And again, feedback is welcome. And we will put this talk up on the Eastman YouTube link, so you will see that. And we specifically want to thank Alan for his time, giving his time, and for his expertise for a wonderful talk. And finally, have a wonderful and safe Thanksgiving, everybody. Thank you all.
Okay, thank you.
Go, Alan.